In this video we will be seeing about squint. Restrictive squint, committant squint, pseudostrabismus, ocular myopathies. These are the four things we will be seeing in this video. First one is restrictive squint. It is diagnosed by forced duction test, FDT, forced duction test. It is a rare presentation, and most common presentation syndromes include Duane's retraction syndrome, which is also called as DRS. DRS type 1, there will be limitation of movement, abduction limitation of movement, abduction limitation of movement, and retraction of the globe, adduction, closure of palpebral fissure. 2 is adduction, loss of movement, and adduction, retraction of globe. In type 3, abduction plus adduction, there will be retraction of globe during abduction and adduction. In type 1, lateral rectus innervated by third cranial nerve instead of sixth nerve. So therefore, impulse for abduction via sixth nerve, lateral rectus does not act, no abduction occurs. On impulse of third nerve, both lateral rectus and medial rectus act. This causes retraction of globe. Type 1 DRS. In this, right gaze, in the right gaze, the patient left eye, this is the right eye, left eye. In the left eye, adduction is present, and left eye, closure of palpebral fissure. Then on primary gaze, there is no deviation. On left gaze, no deviation of left eye, that is no left eye abduction. This is the case of type 1 DRS. Now let us see about Brown syndrome. It occurs due to the congenitally tight superior oblique tendon. Congenitally tight superior oblique tendon. Superior oblique muscle remains contracted. Superior oblique cannot relax. Therefore, it antagonist muscle. Inferior oblique muscle cannot contract. That is the Sherrington's law of reciprocal innervation. Therefore, the patient is unable to perform elevation in adduction. This is the primary gaze of the patient is normal. Right, this is the left gaze normal. Right gaze, it is also normal. Downward gaze, it is normal. These all these gates are normal. The patient is unable to perform elevation in adduction. So, the patient is unable to perform in adduction. The patient cannot elevate. Here there is right eye Brown syndrome. That is a right eye. This is the right eye unable to perform elevation in adduction. Now let us see about the supranuclear gaze. Supranuclear gaze control. Supranuclear gaze control, it is from cerebral cortex. In the cerebral cortex, frontal cortex indicates saccades. That is rapid, involuntary, fixating movement. Horizontal saccade and vertical saccade. Horizontal saccade, it is due to contralateral control. Vertical saccade, it is due to bilateral control. Then cerebral cortex, occipital cortex. It initiates pursuit movement. They are the slow, voluntary following movements. Ipsilateral, IL control. Now let us see about the horizontal gaze pathway. Horizontal gaze pathway. This can be understood by taking the example of left gaze. In the left gaze, left eye lateral rectus will cause abduction. Right eye medial rectus cause adduction. So the net result is eye moving towards left side. The left gaze signal starts from right frontal eye field. This signal goes to left side to parapontine reticular formation. Parapontine reticular formation. That is the center for horizontal gaze. From here, left parapontine reticular formation sends a signal to left side lateral rectus muscle. This causes abduction of left eye and also left parapontine reticular formation gives a signal to right side via medial longitudinal fasciculus MLF, medial longitudinal fasciculus. Via the right MLF, via right MLF, the signal goes to third cranial nerve nucleus, and from there right medial rectus muscle adducts. Then both eye will reach us left gaze. So left horizontal gaze is controlled by right contralateral FEF, that is frontal eye field, and left ipsilateral PPRF, that is parapontine reticular formation, and third is right contralateral medial longitudinal fasciculus. So these three things constitutes the left horizontal gaze. There can be three lesions at three sides. In the left horizontal gaze, number one is right contralateral F lesion. Second one is left parapontine reticular formation lesion, and third one is right medial longitudinal fasciculus lesion. First, let us see right contralateral FEF lesion. Left lateral rectus unable to contract. Medial right medial rectus unable to contract. So both eyes do not move towards left. This is the left gaze palsy. Left gaze palsy. Therefore, FEF lesion leads to contralateral gaze palsy. Then we shall see about the second lesion. Second lesion is PPRF lesion. In left PPRF lesion, left lateral rectus unable to contract. Right medial rectus unable to contract. Therefore, it will produce left gaze. Therefore, PPRF lesion leads to ipsilateral gaze palsy. Then right medial longitudinal fasciculus lesion, left lateral rectus able to contract. Right medial rectus unable to contract. This will lead to left contralateral abduction present and right ipsilateral adduction absent. This leads to left gaze defect. MLF lesion leads to contralateral gaze defect. This condition is known as internuclear internuclear ophthalmoplegia. The most common cause of internuclear ophthalmoplegia is multiple sclerosis.